Dr. Boyce.
Hi, hi Conrad and hi Chris. Welcome everyone. So I'm not at MRF. I'm at home today. So if you hear some dogs barking, chickens squawking, don't be alarmed. There has been an invasion in Port of Spain. So thanks so much, and again, thank you for sharing your Friday afternoons with us. Welcome to MRF HIV STI Echo. I am Dr. Gregory Boyce. I'll be facilitating today. A special welcome to Dr. Jeffrey Edwards, our director. And a special welcome as well to Dr. Chris Behrens, who will be giving us a session today on HIV and ethics. And I think no matter how long any of us have been in HIV care, either directly as clinicians or psychosocial support workers, or even people, just people who live and love people with HIV, these ethical questions keep popping up in ways that sometimes leave experienced providers a little dumbfounded and a little bit confused as to what to do and how to match our duty of care to the client and the patients around them with our ethical obligation to do no harm and all those other things that we learned many years ago in medical school. So I will leave these murky waters to be navigated by the ever-present, ever-popular Dr. Behrens, and I turn over the floor to you to start your presentation, Dr. Behrens. Thanks so much.
Okay, thanks very much. Yeah, it's always a pleasure to deliver lectures for this series. Without further ado, let's get started. The usual acknowledgements of our sponsors. I have no conflicts of interest to disclose. Hopefully, by the end of this, you will have some understanding of the key principles of clinical ethics and a framework for thinking through these ethical challenges, specifically in the context of HIV, but frankly applicable to other areas of clinical care. And we'll discuss a few examples or scenarios that involve ethical quandaries. So let's start with some definitions. What exactly do we mean by the term clinical ethics? Well, it's part of the broader discipline of bioethics. So bioethics can be thought of the interdisciplinary study of ethical issues arising in the life sciences, healthcare, health and science policy. It's a very broad kind of term. Clinical ethics is more focused on patient care ethical issues. And in that context, we are trying to clarify why certain actions might be right or wrong. And we do that using ethical reasoning and the application of bioethical principles to hopefully resolve the ethical questions at hand. The core principles of bioethics are these. Sometimes you might see a couple others, but I think these four are really at the heart of it. And so if nothing else, I'd like you to come away understanding these four terms. One of them is beneficence. It's the duty of the clinician or healthcare provider to help the patient advance their own good and the duty to act in the patient's best interest. Another core principle is autonomy. This involves honoring the patient's right to make their own decisions and for self-determination. There is, of course, non-maleficence, do no harm. You know, one of the key principles of the Hippocratic Oath. And then last but not least, justice, a certain sense that we need to be fair in how we provide care and how we allocate healthcare resources. Now, this is kind of an arbitrary, order of listing. It does not imply a certain hierarchy of importance. No single principle trumps the others. And so the relationship between these can be dynamic and frankly often requires balancing one or more against one or more others to try and resolve an ethical dilemma. So this is a framework I mentioned earlier about how to try and resolve ethical questions. And it's kind of a sequence of steps of sorts that may not occur exactly in order, but essentially it does start with trying to identify what exactly is the ethical problem or dilemma we're confronting here. We need to understand the medical facts of the situation. We need to know the available diagnostic and or treatment options, depending on the context. We need to understand the concerns of the clinician or medical team, as well as the preference of the patients, their goals, values, and priorities. That's, of course, the autonomy issue at play. We need to be able to articulate how the various options will impact the quality of life of the patient. So this sort of gets at beneficence and non-maleficence. We need to understand any contextual features relevant. So there may be laws, regulations, hospital policies that are relevant to this situation that also need to be factored in. And so hopefully by doing all this, we can identify the ethical principles that are in potential conflict, because if there's no conflict, then there isn't an ethical dilemma here. And then ideally, we are able to identify some, practical considerations and hopefully come up with some kind of a solution. So I think the best way to go about this is to actually present a scenario and try and work through it based on the framework I just presented. So let's say we have a woman who has no history of prenatal care, but she shows up to the hospital in early labor. We do have some blood that's already been drawn for, checking her Rh type and things like that. She has risk factors for HIV infection. You recommend HIV testing, but she refuses, despite your best efforts to educate her about how knowing her HIV status could make a big difference in terms of reducing the risk of possible mother-to-child transmission of her HIV. And so the question is, what do you do about this? Let's actually start with a poll right now and see how people respond to this. It's an anonymous poll, so feel free to answer whatever you think might be right. Should we abide by her wishes, not test for HIV? Should we go ahead and perform a rapid HIV test on the blood we already have without telling her? Or should we perform HIV testing on the blood we already have, while being transparent that we feel compelled to do so for the sake of the infant?
And feel free to just choose 1, 2, or 3 to give your answer in.
Mm-hmm. Okay, so I think we've given that enough time. Let's go ahead and show the results. And good, I kind of like this. There's a mix of responses. Exactly 2/3 of you felt like the first option is the most appropriate, just abide by our wishes, don't test for HIV. Well, 1/3 suggested the last option, performing rapid HIV testing while telling her why we are doing it. Oh, sorry, I think maybe I had not shown the results before. So that's sort of the breakdown of your responses. Now, those of you who are hoping for me to now present the answer, I'm sorry to disappoint you, but the nature of many of these ethical questions is that there is no clear right or wrong answer here. And so I put this out here as an exploration, really, of how we approach this particular ethical dilemma and what our options might be in the end. And it's, it's perfectly reasonable and appropriate for people to not agree on what is the right thing to do. So, let's think about this a little bit and see if we can apply the framework that I mentioned earlier. In terms of identifying the problem or dilemma, my take, well, actually, I'd like to open it up. Would anybody else, like to sort of articulate what they perceive as being the problem or dilemma here?
Sorry, I didn't raise my hand, but I put my response in the chat.
Oh, thank you, Alana. Brave soul. You wrote that you were tempted to test, but no, it's illegal, and would have no way to explain afterwards if she was HIV positive. Yeah, okay. Yeah, so that's really a dilemma for you, right, as the healthcare provider. So it sounds like there are laws in place that are applicable here. And can anyone speak to what the policy, regulation, or law is in this situation? I'm guessing it's simply that you absolutely cannot do HIV testing without patient consent. Mm-hmm.
Hi,
Okay.
Chris. Gregory here. So that's part of it, that consent is required for HIV testing. But because I remember having an argument with an OBGYN consultant about this, and the law also says that the fetus is not a person. So you cannot intervene on behalf of a non-person. Right? So even though there is likely to be harm, for example, as a result of not doing something, we cannot take what's best for the unborn baby into consideration, because legally that's not a person. So the mother can choose to do something that may be directly harmful to the unborn child, and there is no legal consequence for so doing. So we can't compel the mother to either take an action or to not take a certain action based on what's best for the baby or the unborn baby.
Mm-hmm. Okay, yeah, so that's very helpful to know. And remember, it is part of the framework here. I think it's like the 6th bullet or 7th bullet down. Understand any contextual features relevant to the situation, laws and regulations. Alana has another comment. When you were pregnant, it was given as a choice, important stressed. But your private OBGYN just told you he was taking it and didn't present it as a choice. Interesting. So in this particular scenario, I didn't say, how it was framed, but the end result is that it was simply refused by her. If it's an opt-out test, I wonder if in this situation, it would have been reasonable to simply do the test without asking, at all up front. Is that, do you think that would be okay? Given that it is an opt-out, does opt-out require that the patient be informed that you're doing the test? Because that's my understanding of what opt-out means. But I'm curious if that aligns with your understanding.
My understanding was that you present it as an option. You go through the positives and the negatives, that sort of thing, and then the patient can decide whether or not they want to be tested. That's what I understand. I understood as opt-out.
Mm-hmm.
Someone can tell me when it's wrong, but that's what I was told.
Conrad, I think you raised
Yeah.
sorry, I can't necessarily see everything.
That's fine. So my understanding really is that the choice of opt-out is really it's there in those facilities so that persons are aware of it. The person that is actually conducting the test is supposed to let them know that as part of the range of tests that they're now going to be doing, that doing an HIV test is also part of the standard. The person can then make the decision to opt out if they want. But it's really about whether or not the person who is there as the tester, if they actually inform them, because part of the challenges is that the information is supposed to be in the facility on walls and things like that. So does the tester inform them that this is being done as part of the group of tests that are being performed now? And so it really comes down to what the individual tester does, I think.
Yeah, that pretty much aligns with my understanding what opt-out is. What it's all about really was that initially with HIV testing, it was required to do a very lengthy, counseling before people could even get tested, and it was just too cumbersome to implement. And so an approach that really came out of sub-Saharan Africa, where the epidemic was so much more severe, was that we need to make this routine, and we need to get rid of all this pre-testing, counseling and consent. So that's where opt-out approach came from. The idea of saying, look, this is just something we're going to be routinely doing the same way we screen you for diabetes or screen you for hypertension. We're going to screen you for HIV, but they do have to be informed. I guess what I'm taking away from this conversation we have so far is that the problem or dilemma we have here is we've got two sort of conflicting principles, ethical principles here. One, of course, is patient autonomy. The mother doesn't want to be tested, but that's in contrast to the sort of beneficence or non-maleficence, however you want to frame it, to the fetus, right? And that's why this is such a challenging situation. We understand, I would say, the medical facts, the available diagnostic testing and options. I think the concerns of the clinician medical team are clear, wanting to prevent, or at least do everything we can to prevent an infant with HIV, while understanding the preference of the patient and their goals not be untested. And then we get to the contextual features that's really relevant, which is pretty clear legal framework saying you cannot do this. So does anyone have anything else to add about this scenario? Has anyone ever seen it actually come up or aware of a case that this happened? All right, let's move on to another. We've already sort of covered these. I guess I forgot to mention, I would say that there's another, it's not just the interest of the infant, it's interest of the society. An infant infected from birth, that imposes considerable additional medical costs throughout the lifetime of that infant child all the way through adulthood. So there is some relevant, cost to society as well to take into account here. All right, let's do another scenario. You're caring for a nurse who has just sustained a needle stick injury. The source patient has risk factors for HIV. You already have blood from that source patient. You ask for permission to perform HIV testing. He refuses. So what do? We're in a fairly similar situation. Abide by his wishes and do not test. Test the blood for HIV anyway. Inform the patient why you are doing so. Or test, but do not inform the patient that you are doing this. Okay, we've got some decent number of responses here, so I'm going to end the poll and share the results. Hopefully you can see this. So again, we have honestly a nice distribution of answers. At least one of you picked every possible option here. So let's talk about that a little more. I'm seeing a comment in the box from Jeffrey Edwards: would not test the blood, but start the healthcare worker on HIV post-exposure prophylaxis. So, okay, that's another option. Alana says, I feel like my decision depends on if the patient was at a clinic getting an HIV test, in which case you'd go ahead and test. The patient was at I see. Well, sure, if they were already there to get a test, but then presumably they wouldn't be refusing this HIV testing. Maybe I'm missing something. Okay, so Alana, do you want to talk? Go ahead.
Yes, I do. If the blood was already drawn for that purpose, I'll just go ahead and test it. That's what I'm thinking, because I didn't know if the patient was there for some other reason, but they said the blood was already drawn. I didn't know if HIV was one of the tests that was going to be done anyway, in which case I wasn't going to ask.
I think the scenario I'm thinking of here that I had in mind, and maybe I should be more clear, is it's like a patient in the hospital who's sick with something and has already had some labs drawn for other things. And then while doing a blood draw or some sort of procedure, a nurse has a high-risk needle stick injury, and therefore would like to know whether or not that source patient has HIV. So yeah, kind of that's what I had in mind. I'm guessing the same sort of law applies about not doing HIV testing with consent. Has anybody, I'm just curious, have any of you seen, heard, or been involved in a scenario like this? Because this is something I have come across. I was sort of a consultant for a post-exposure prophylaxis hotline here in the United States for a while. And interestingly, the laws around this, they actually vary from state to state. So in some states, it is legal to test the already drawn blood for HIV, even if the patient refuses. And I think the basis of the law was a sense that, you know what, we're not doing any harm to the patient, the blood's already drawn. And there are implications for this healthcare worker who, keep in mind, legally, even in Trinidad and anywhere else, this is, we're not dealing with a fetus who is, might not be legally classified as a person, but we're dealing with another healthcare worker. So some states in the United States say it's okay to override the wishes and the autonomy of the source patient in this scenario. Other states do not. I don't know if Trinidad has carved out any kind of exception legally to the HIV consent in this kind of situation. Does anybody know?
Hello?
No.
Hi, yes, we're hearing you. Go ahead. Somebody say something.
Yes, that's me. I haven't been on the call for a very, very long time. This is Valerie Smith. I'm in Florida.
Hi. Hi.
Hello, I'm HIV surveillance. I'm sorry I'm late. But I do know what you're talking about, Dr. Behrens. Here in Florida, if someone is in the hospital and there's a needle stick, as long as the blood is available, the hospital is allowed to test.
Mm-hmm. Yeah, interesting. And it's the same way here in Washington State, by the way. But I know some states it's not that way. My hunch is if there were that sort of exception carved out, you might know about that in Trinidad, but I really don't know. Can anyone comment on what you think the law might say about this scenario?
Well, so the guidelines, I'm not sure if it's codified in law yet, but at least the testing guidelines do require patient consent, essentially regardless of circumstances, even non-occupational exposure, in the context even of a sexual assault. The source cannot be compelled to give a sample for HIV testing. So we come across this actually not that uncommonly, whereby someone's had needle stick injury and the patient refuses to give a sample for a test.
But there is a subtle distinction here, though. Compelling a patient to actually give a sample, meaning like undergoing a blood draw, that is a bit more, a step above and beyond. But in this particular scenario, we already have the blood, so they don't even have to provide a sample. Do you see what I mean?
I got you, but I still believe it. Oh, Dr. Musa, go ahead.
No, yeah. There's some good afternoon. There's a little question that has been crossing my mind, because even if you already have the blood, but the patient has said they don't want to have the test. If you do the test and it's negative, God bless you. You're lucky. But if you do the test in the blood, which is already drawn, and the test is reactive, what do you do with the report? Do you go back and tell the patient that he didn't want the test, but I did it anyway, and you need to go for treatment? Because if it leads to yet another problem. And just to add that in Trinidad, HIV is not a reportable or notifiable disease. So that caveat is also there. Over.
Yeah, excellent point. And it really underscores the importance of sort of thinking ahead as we have to do with any test we order. What are we going to do with the results, especially in a tricky situation like this?
Can I interject and ask for the previous speaker to repeat what he said, that in Trinidad, HIV is not a reportable disease?
No, it is not. It's not a notifiable disease. It doesn't fall under Public Health Act.
Oh. That's interesting.
Yeah, that kind of surprises me, actually.
Yeah, I thought it would have been. Okay. Now I'm speaking based on we have we deal with so many variations of what happens in a hospital setting. I think in the hospital here in Florida, again, if the situation is that the blood is available and there's some suspicion, especially depending on the condition, the reasoning, if the patient comes in and they're very sick and they have all the classic symptoms of someone who, has HIV or something like that. I'm just saying that's a caveat. Then definitely they will go ahead and test that blood. I mean, if there's a suspicion that this person may be HIV positive, or even if, based on the history, when they take the history, if it's from the patient, if the patient is well enough to give some sort of health history about what their health is like, what they've been going through in the last, recently, their last visit, whatever. And if there's a suspicion, in that sense, then that would, I guess it depends. I guess again, it all depends on that specific scenario as to when they cannot do a blood draw without the patient's permission. But if the blood is available and they suspect that HIV is a part of the problem, and there's a finger stick, definitely a needle stick, they will definitely test it. Because at the end of the day, I guess the thinking is you've got a nurse, a doctor, a medical professional who is at risk, and they would definitely have to send that professional for evaluation, testing, whatever it takes to make sure that that person is okay. And for us, we have that NPEP medication that can be administered to someone who's in that position within the first 72 hours to help with the infection from proliferating itself. I know it's very different from state to state here in the United States, but I'm sure it's also very different as we're learning from places like Trinidad.
Yeah, interesting. Now, Dr. Edwards had a kind of I think a practical suggestion. Well, okay, we can't, he felt like we cannot legally test. However, we can simply put that patient on post-exposure prophylaxis anyway, essentially assume that this exposed healthcare worker has, assume that the source patient has HIV and treat the exposed healthcare worker accordingly. And that makes a lot of sense to me. But I'm going to throw a little wrinkle in this scenario and say, well, what if this woman is pregnant in the first trimester of pregnancy and she would really rather not, expose the fetus in the first trimester of pregnancy to these medications. So kind of raises the stakes a little bit about actually knowing. Does that change anyone's thinking about this? And I'm deliberately framing it, as a very real sort of a conflict between autonomy of the source patient and, beneficence or non-maleficence for the exposed healthcare worker here.
Go ahead, whoever was.
You said, I think unfortunately we would be in the same position that we cannot compel someone to do a test against their wishes, regardless of the situation, unfortunately, at least based on the guidelines in Trinidad. Even if you have access to a sample staring us in the face, I would offer take a fresh sample. We would be against the testing guidelines of the Ministry of Health to do a test on anyone, regardless of the circumstances outside of their consent. So yeah, it's difficult.
Yeah, I hear you feel legally bound to not test, but like you said, you've got this sample of blood staring you in the face, and it somehow, it doesn't feel comfortable, does it? Just following the law. And I think it's worth making this distinction that,
I think I was introverted because I like being alone, but it turns out I just love being.
Hello? Oh, sorry. I think it's very useful to distinguish, though, that what the law says or what policies say aren't necessarily going to be the most ethical. It does not necessarily align with the ethical issues or the right ethical solution to a given situation. I'm not that I'm necessarily saying that ethical considerations should override the legal considerations here, but I think we're all aware of situations where the right thing to do is not necessarily what the law says. It's frankly the whole basis of civil disobedience and all kinds of actions that from other contexts, other historical situations that sort of were the right things to do despite the not being legally permissible. So again, I don't feel like there's any clear right or wrong to this situation. Right, and so that's why I'm posing these cases, to make us kind of squirm and struggle to figure out how to balance these. Let me pose another question. Are there, in the hospitals or clinics, this is more relevant for hospitals typically, or medical systems, are there ethics boards to whom you can appeal if you are confronted with a difficult ethical situation? And I'll just give you an example that's really pretty common here in the US, and I suspect you would or can confront in Trinidad as well. Individuals who are just terminally ill, and there is absolute medical futility in continuing to keep them alive, whether it's on a ventilator, for example. But there is no sort of living will from the individual who is now totally unable to respond, and the family refuses to let go, and wants the hospital to continue doing everything possible, despite the fact that the team believes that there's nothing more that can be done, and that this is a terminal situation. This is a situation that comes up very frequently here in the United States, and what is very often done is an ethics board of the hospital is consulted, and there are clinicians who are particularly well versed in bioethics who sort of consider the case and pass along their recommendations. Is that resource available to you in Trinidad?
We have this, it was a very long time ago, and you might remember that right here in St. Petersburg, Florida, that it had nothing to do with HIV, of course. It was a husband and wife situation where she had a massive, she was very young, I think in her 30s, and she had a massive stroke, and literally couldn't do anything. I mean, she was basically brain dead. Do you remember that? It was a long, drawn out, the case was going in and out of the court system and all the way to the Supreme Court for over 15 years, because there was no directives between the husband and the wife that was ever prepared, because when you're that young, I think she was like 35 or something when it happened, nobody's thinking about that sort of a tragedy. And so after a few years, the doctors told them very early on there was nothing, that there was no brain function. She was on life support. Her parents were devout Catholic, and the husband, after a number of years, he wanted to move on with his life, and I don't think it was necessarily because of that, but hey, he's in his 30s and she's brain dead, and he didn't want to have, because he was the spouse, he was the one that had to make the decision, but then her parents fought him in court. That was a big battle. I mean, that was a long, more than 15 years they had her on life support. Do you remember that case?
I actually do.
I do too. Because I think finally they agreed and they stopped feeding her, and she eventually died.
Yeah, but then her parents, they brought a civil lawsuit against him because he was next of kin, literally, legally, and despite what they wanted, he made the decision. But I don't know what ever happened to the civil case, because they, because of their religious beliefs and stuff, they were accusing him of killing her. So, you know.
Yeah.
But these, you know, with the HIV situation, I'm just asking questions. I know I haven't been on these calls for a long time, but I wanted to get in on this one, because this is what I do every day. And I was interested in knowing in Trinidad, for example, in this scenario. Okay, so the person, you know, is maybe suspected, I don't know, for HIV. It's not a reportable disease, but is there any documentation that's kept after? In any, you know, is there any documentation for future reference about this patient? If it's determined that that exposure actually was, because for us here in Florida, there's documentation. You have to keep record. I mean, regardless of what the situation is, it has to be documented. If there's whether or not the patient agreed to be tested or whatever, there's documentation all the time. So in the event something comes up,
it should be documented. Let me be careful with my words. It should be documented that the patient refused to have a test, because otherwise the clinician would be might be called upon to explain why the test was not done. So you would have to indicate very clearly that you wanted to do the test, you offered to do the test, but the patient refused completely.
Okay.
Yeah. I mean, something not related. There was a time I was looking after somebody who had extremely high blood pressures, but regardless of how much I pleaded with him, he told me he wasn't going to the hospital. But I told him, for his sake and mine, I'm going to give him a referral letter to the hospital, because if anything happens to him, I won't have anybody defend me. And he actually refused to go to the hospital. And I think the same week he had a massive cardiac myocardial infarction and severe intracranial bleeding, and that's when the relatives rushed him to a private hospital, and he died the same day.
So when it comes to HIV, just like in the United States, a lot of the laws and the rules can differ from state to state. As you get deeper and deeper into the legalities. So in Trinidad, is there, since it's not reportable, is there anything out there that's on the books that says if someone knowingly, maybe they were diagnosed already by whatever means, and they knowingly, let's say, enter into a sexual relationship with someone else, but they never disclose their status. Is there anything in the laws that says that individual who is a known HIV positive is liable for infecting another person?
So, Dr. Boyce here again.
Yes.
So there's no HIV specific law. It was under consideration some years ago. But I think when they did a legal review and examined what the potential impact of having HIV specific legislation might be on people's willingness to test and come forward after diagnosis, I think they decided against it. But it is covered under the Offenses Against a Person Act. The same sort of laws I think would cover like assault and grievous bodily harm and that sort of thing.
Okay.
So there is ability in law for someone to seek redress if they believe they were deliberately exposed or deliberately infected.
Okay.
Yeah, and I think you you anticipated the next scenario I was going to present. So maybe perhaps we have time just to do this scenario, because I'm curious how people would respond to this. You have a patient. He's a 29-year-old HIV infected man. He refuses to take ART. You discover that he's been having unprotected, consensual but unprotected sex with multiple partners without disclosing his HIV status. He adamantly refuses to change his behaviors, stating that his partners should know the risks of unprotected sex. And he rarely comes to clinics. So what do you do? Should you report him to law enforcement for endangering the lives of others? Should you report him to public health for posing a public health threat? Or should you continue counseling him as best you can that he really should change his behaviors? So I'd like to see what people think of this situation. Okay, so let's go. Great, we've got about 8 responses here. In the interest of time, I'm going to go ahead and share the results. So a couple of you said report him to public health. Most of you said just continue counseling him. This is a tough one. Patient autonomy versus non-maleficence to others, including sort of public health. And there was a scenario like this. Well, this has come up in the United States, and I recall a case many years ago involving a specific individual in a city not very far from here who was doing exactly this. Public health and law enforcement did get involved, and I think there may have been a lawsuit as well for this individual. So I certainly don't know the answer to it, but I'm wondering if this scenario has come up, or have there ever been any cases in Trinidad like that, or has anyone ever confronted this kind of situation?
Let me say that I've come across a few cases like this, especially where somebody knows about their HIV status for years, but for one, they even falsify an HIV report, which shows that they're negative, though they have the infection. And when their partners go and test and find that they're positive, they deny completely that they knew anything about their HIV status. Now, I think ethically, as a clinician, I can't go to the police or to the court of law and tell them that this person, or go and tell his partner that this person knew before they met you that they were HIV positive. So it happens, but the hands, I think, of the clinicians are tied as to what you can do. I mean, the best you can do is maybe, if you know the partners, is to find a way of informing them that they need to go and have a blood test done without telling them who they might have been in contact with who is HIV infected. So it's tricky. Over.
But our hands really totally tied here. I mean, as clinicians, we routinely notify, well, it's not exactly law enforcement, but we notify, Child Protective Services if we suspect child abuse. In fact, we are required to do so. We notify Adult Protective Services if we suspect elder abuse. If we diagnose, I know at least here, where I work, if a patient is diagnosed with an STD, we encourage partner notification, but if the patient in front of us doesn't feel comfortable notifying their sexual partners, then we turn to public health and say, look, here's this individual who has sexually transmitted infection. Can you please try to track down their sexual partners? And then public health will anonymously inform them, you know, those partners, that we have reason to believe you've been exposed to a sexually transmitted infection and you should get tested. So
Yeah, that's exactly, I work for the Department of Health in the state of Florida. So what you're describing is exactly the way it's done here. And we have, every day we have those scenarios where the patient is not comfortable in notifying the partner. And then we also have those that will tell you they're going to do it and they don't. So the key for disease intervention investigation here is to, at the time of diagnosis or treatment, we try to get them to disclose the partner information, and we give them the opportunity to do the notification themselves. But after a certain period of time, we have different, number of days, we will reach out to that partner and say, we have reason to believe we have to choose our words very carefully. You may have been exposed to XYZ, and then let them take it from there. But at no time can we disclose the identity of the partner.
right. But in this, yeah. So okay. So yeah, and that's how we do it here as well. And maybe that mechanism exists in Trinidad. In this particular case, the difficulty is we don't know who the individuals that have been exposed by this patient are. And there's this ongoing behavior. He rarely comes to clinic. Our counseling efforts have made no difference. I guess what I'm wondering is, we wouldn't hesitate to engage with public health or even law enforcement if we suspected child abuse, right? And yet here's this individual who's clearly posing a significant health danger to other individuals. Shouldn't we be trying to do something beyond the counseling that has been so, futile to date? I'm not sure, but I think it's a difficult situation, and which is why I put it up. Okay, someone raised their hand, Dwight.
Hi, good afternoon. This is Dr. Hoyt from Tobago. So it's a group of us listening in. Just to share that I think the way to go definitely is the counseling, but there's also a benefit in informing public health. Not that there are laws that we have locally that could do anything, but to help have sensitization campaigns just to remind persons about risky behaviors as such. And I think one of the things as well is to remember to try and elicit what might be the barriers, because some persons are afraid to disclose if there's going to be intimate partner violence and stuff. So sometimes if you are able to assure them their safety and stuff, things like that may also help with getting them to have their partners notified.
Thank you for that. I know here in the United States, there are precedents also for patients who had infectious tuberculosis living in New York City, who really ended up getting essentially incarcerated to take them out of the community and try to get them on treatment. It was it was really a drastic public health measure to prevent ongoing transmission of tuberculosis by individuals who refuse to, engage with treatment appropriately. Also have a more, even a local case very recently, kind of like that.
Hi, Chris Gregory here again. So there is some legal precedent. So because our Court of Final Appeals, the Privy Council, we are still governed by a lot of the laws in the United Kingdom. And there is stuff in the General Medical Council in the UK, as well as, can't remember the name of the other body as well. But in terms of when do you disclose confidential medical information against the wishes of the client, there was some case law some time ago, and I would urge everyone to go to General Medical Council of the UK's website, actually check on this, because they have good guidelines on it.
But that's okay. I wanted to.
So, essentially, the case that was quoted some years ago, and the case may have evolved over time, but it was actually a married couple where I think the husband went somewhere on a business trip, got chlamydia, came back, spoke to his GP, got treated, asked the GP to not tell his wife. The GP decided not to tell his wife. In the interval between him returning to the UK and seeking treatment for his chlamydia, he had by then infected his wife. The wife went to the same GP, got the same treatment. She recognized, I think, that, but this is the same pills my husband is taking. Are you treating him for chlamydia, and why didn't you tell me? And she actually sued the GP and won the case because there was risk of harm. And for example, if in a doctor's office, my client tells me, pulls out a knife and says, I'm going to go home and stab my wife to death, I call the police. There is no confidentiality in those circumstances. If my client is an epileptic who's poorly controlled and has a job as a bus driver, I inform the Ministry of Transport as the employer. He cannot do that because there's risk of harm to the public. And what essentially that case was illustrating is that if there is potential for harm to others, there is consideration for breaking confidentiality. I think the law is evolving now, especially with HIV is no longer a fatal disease and you can get treatment for it, and it's more of an injury rather than a life-threatening condition if you think of the transmission event. But I remember reading that case, this is several years ago, and being concerned that if that is a legal precedent that is governing issues surrounding disclosure of communicable diseases, then we may be in a bit of a sticking point in Trinidad, because we are advised that we cannot disclose because of privacy confidentiality, yet this is the governing legal framework that is going to judge us if, let's say, one of our clients' partners comes in, or ex-partners comes in, having been infected with HIV, sees the ex-partner in clinic and says, wait, you were coming all the time and nobody told me. I don't know if we have a legal foot to stand on. So this issue has been troubling me for years. I don't think we have a good resolution to this yet.
Yeah. All right. Well, thank you. This has been such a rich discussion. Do we have time for one more comment, question? I know someone has their hand raised, but sure. I also there was sure. A request to allow time for a final poll about this series in general. So I'll defer. Do we have time for? There was a hand raised, or do we go straight to the poll?
Oh, I think the hand went down.
Oh, okay. All right. So I'll turn it over to you, Dr. Boyce.
So I may have to defer this Conrad there because I haven't been able to see any of the posts today. I don't know why.
Not a problem. So we this is actually the last series, the last in the series that we've been doing with Dr. Behrens, as well as the last session that we have for this ROP year. We want to thank all of you all who've been attending, and those who are here for this session today. In particular, we want to ask you to just quickly fill out a very short poll first. It's just 5 questions, just answering a couple of questions. It's very helpful for us because it gives us information that will help us make the series better for you. And so if you have an opportunity to, please go ahead and just fill this out first so we'll be able to get that information from you. I don't know if I can pass back to Greg to give information as to when we're coming back in the next ROP year. But ECHO is going to be back. The MRFTT HIV STI ECHO is going to be coming back to you, most definitely. And so again, we just invite you all to fill out this poll for us. Greg?
Yeah, okay, so while that's going on, so I think we'll probably take a break for the rest of September and restart sometime in the new financial year in October, once we sort of get everything lined up in terms of the topics we're going to discuss and those sorts of issues. So probably by next month, within a month from now, we should be able to notify our learning group or ECHO family as to when the first session will be and which session it will be.
And if you also just allow me to underline, Greg, the ECHO is going to be coming back with a brand new look, which will allow you, the first time you join, to kind of give us your information and log in, so that every time you do log in, we'll know that you were here and how long you were here for. It'll provide us, again, with important information, how many clinicians are joining, how many nurses, and allow you to also give feedback on these sessions that you come and join on a real-time basis at the end of each session. So thank you so much on behalf of all of us from the MRFTT HIV STI ECHO. Thank you for joining us today, and we will see you again in the new ROP cycle.
Thanks, everyone.
Thank
Thanks, Chris. Take care. Have a good weekend.
Thank you all. Thank you so much, Dr. Behrens.
Oh, you're welcome. Thank you. Great discussion today.